You're listening to the ATS Breathe Easy podcast, brought to you by the American Thoracic Society.
Welcome, everyone. We are back with another exciting episode of the ATS Breathe Easy podcast. And I am here. It's actually really exciting. We are having bringing back some of our previous podcast guests for an episode again on asthma and biologics. And so I'm here again with Dr. Monica Kraft, who is chair of the Icahn School of Medicine at Mount Sinai and an expert on everything asthma. And I am also back with Dr. Dee Gardner. So she is a Chief Medical Officer for the Asthma Allergy Network. And so we are really excited to be talking about the recently approved biologic that can be given every 6 months, and kind of what the clinical implications of that are for depemokimab. Again, we're really excited to have you both here, Dr. Kraft and Dr. Gardner. Thank you.
Great. Thanks for having us.
So yes, I think just kind of diving into the really exciting FDA approval for depemokimab. And I think we were going to talk first about some of the background about this biologic and kind of how it works and how it can be dosed every 6 months. Dr. Kraft, what are your thoughts on this?
Sure. Well, I have to say being in the asthma space right now is great because there are so many trials going on with some very exciting therapies. We have so much to offer our patients that, when I got into this business, we just didn't have. And so this is another example of a biologic that's now a much longer acting biologic than we've actually had access to, in the past. So depemokimab is it's a long acting monoclonal antibody that acts against interleukin-5. And if you remember IL-5 and what it does, it does several things. It's known for certainly reducing, affecting eosinophil function, eosinophil levels. But there have been some very exciting data of late suggesting that it does a lot more in terms of really allowing the airway epithelium to repair, reducing the laying down of collagen in the airways, and affecting other arms of the inflammatory cascade beyond the eosinophil. So that's been a very nice, sort of a way to understand, why we're seeing these nice improvements in our patients. So we've had an IL-5, actually we have 3 IL-5 biologics at our disposal right now. We have mepolizumab that's given monthly that also targets the IL-5 cytokine. We have benralizumab, which targets the IL-5 receptor. And then we have reslizumab that also targets the IL-5 cytokine given in an IV form. So we've had access to these. And the benralizumab is dosed. Usually, it's once a month, and then once every 2 months after the first couple of doses. Then the reslizumab is much more often as a weight-based IV form. So very different. All 3 are very different. So what I like about depemokimab is that it's now dosed every 6 months. So you imagine getting an injection of a biologic twice a year. Very different than the situation we're in now, where most of our biologics are either every 2 weeks to a month on average, with benralizumab going a little longer. And so the results of the trials that really led to its approval were impressive. There were 2 trials called SWIFT-1 and SWIFT-2, and they looked at about 762 patients who were given, and it was a 52-week trial, actually 2 trials, and showed a very nice reduction in exacerbation rate. The SWIFT-1 showed about a 58% reduction in exacerbation rate, SWIFT-2 about 48%. This is pretty close in line with other biologics. There have been a few that have actually had slightly higher reductions in exacerbations, but it also showed a reduction in hospitalizations. There was some pooled data showing a 72% reduction in the rate of exacerbations when you put the 2 studies together, sustained eosinophil suppression, and so those are all very positive. And safety-wise, well tolerated. What it didn't really show so much is changes in quality of life or changes in lung function. Some of the other biologics do show some of these outcomes, especially the lung function change. We see that with some others. This one, not so much. So that's just the way it is. And mepolizumab doesn't have huge change in lung function either. That's probably the biologic that it's most closely related to. And then, so that was just approved in December. And then and then very recently, it's been depemokimab is also approved for for nasal polyps, chronic rhinosinusitis with nasal polyps. And so a nice study in the Anchor 1 and Anchor 2 studies in JAMA showed some improvement in nasal polyp reduction, actually reduced the size of the nasal polyp, improved nasal obstruction, and was also very safe. So overall, it's nice to have a choice of a long-acting biologic, I think, at our disposal.
I think you had mentioned, I think in the previous podcast, it's like you have to send a reminder to yourself to go like every 6 months to get your...
Exactly. Now, what we are hoping to gain some more experience with is how patients will feel toward the end of their 6 months. Because in some of the patients who receive biologics every month or every 2 weeks, they're starting to feel it by the end of that period that they're ready for the next dose. So it'll be interesting to see if that happens with depemokimab as well. The trials didn't really reflect on that a whole lot, as you might imagine. That's a very patient sort of a very personal outcome. So it'll be interesting to see how our patients do with that, and if they feel like they'll have to give themselves a reminder, or maybe they'll just know that it's time for the next injection.
Oh, that's a good point. Okay. No, that's good to know. And I think so that's, again, talking about a game changer. And we wanted to talk with you, Dee, about what your thoughts are on how patients would respond to this, like having a treatment every 6 months.
Yeah. No, it's very exciting for our patients, especially those that might not be a real fan of injections, right? That getting an injection twice a year versus more frequently. But also hearing from our patients, learning about this medication coming to light is exciting for them because they will have the opportunity to have less doctor's visits, having their asthma get improved. And then also, even though this may not have shown quality of life improvement, we do recognize that there are mental health concerns that go along with having severe or uncontrolled asthma. And so being mindful as a patient to have conversation with a physician to recognize what these signs and symptoms might be as you're coming to the end where you need to get your next dose is making sure that education is taking place.
My take on the study, so there was an improvement in quality of life. It moved in the right direction, but I think there was a placebo, right? The placebo arm also had an improvement in quality of life, so it ended up not being significant, but it seemed like quality of life was moving in the right direction.
Yeah. I would agree. Also, I wanted to also correct what I just said. So depemokimab is being looked at for EGPA, which is the eosinophilic granulomatosis with polyangiitis, or the vasculitis associated with asthma, and for hypereosinophilic syndrome. I don't believe it's being looked at for eosinophilic esophagitis yet. So I wanted to make sure I stand corrected on that.
And the tool that was used to measure quality of life, the St. George questionnaire, was intentionally long ago used for COPD. And so translating it for a person with asthma, some of the questions on there may not actually reflect the signs and symptoms that they're having. And so, maybe one day we can have PROs that are actually patient co-created versus these others. So looking forward to that.
Yeah, I was involved in a study working with my European colleagues, and we used the European Quality of Life score and did see a change with that. So you're so right. It depends on the scale that you use, and is it appropriate for asthma?
Yeah, again, that's good to know, because I felt like when I looked at the study itself, I was like, well, it is improving in quality of life. It was just, there was the placebo arm also moved in that direction. So,
and we do see that in studies. When patients get into studies, they take better care of themselves. They take their controller medications, and generally their asthma tends to do better. And so that may be a driver of why quality of life improved in a placebo arm.
Kind of my takeaway, it sounds like we're all kind of on the same page that having a 6-month dosing strategy is like such an improvement in quality of life for patients and their adherence. How do we think about like the 6-month strategy? Like, are we going to want to see them before the 6 months, or what are we kind of thinking with this change?
Yeah, good point. I think, I speak to some of my clinical colleagues who take care of patients in this space. Certainly there's patients who are already on mepolizumab, which is a monthly dosing, would be good candidates to transition to depemokimab, because I think it's gonna take patients a little while to sort of warm up to the fact that, especially with a new start, taking something that could last 6 months. So on the one hand, I think people really love that, because I'm getting a lot of, I don't know if complaints is the right word, but sort of commenting on how long do I have to give myself an injection, so often. It would be nice not to have to do that. Then I have the other side that says, well, this is a new drug, and so it's going to last 6 months. So what if what if I have side effects? And so what I do is try to reassure that group, the new start group, that, the studies really didn't demonstrate a lot of adverse events at all. It was very well tolerated. There were the anti-drug antibodies that have sometimes come up in the trials were really infrequent. And so I feel reassured about that. So I try to convey that. But I think as time goes on and depemokimab is around, is available to us a little longer, I think there'll be a familiarity. But certainly, if I started a patient on it, which I'm about to, I would definitely see them before the end of their 6 months. I usually, any new biologic start, I'd want to see them usually within a month or two anyway, just to make sure everything's going okay. Checking their eosinophils, things like that, making sure there's no unexpected effects.
And the education, I think, setting those realistic expectations, as you just talked to about, Monica, is that I think that's the key for patients, is knowing what they can expect and what to do if the shoe falls. What do I do? And we do recognize that many, our patient advisors, they do speak to, mental health, having severe asthma, having these exacerbations, ending up in the emergency room, ER, urgent care visits over and over and over again. And just, having this option now where they can get their asthma under control. What does that look like? And then on top of that, as they're moving through their day or through their weeks or months and not having anything, that is a shocker for them. We've heard patients say, is that going to be real? Are you sure that's how it's going to work? And we too, in our education, try to reassure that, yes, this can be real.
Yeah, it's really gratifying, isn't it? Because, in the early days, or at least in my career, we had, oral steroids, and then inhaled were advancing and becoming more potent, and different kinds of formulations were really benefiting patients, but they just didn't really, it wasn't enough. And so to have this, this whole extra class, if you will, of treatment is really exciting, and to see patients do well and get to live their lives and do the things they want to do is really gratifying to see.
Yeah, I have to say, so I probably treat COPD more than asthma, but so this is newer to me, this experience of patients coming back and feeling so much better. But I have to say, it's so gratifying to see.
Early bird registration for ATS 2026 in Orlando is now open. Register now and save. Members get a discount, so become an ATS member or renew your membership to take advantage of the savings. Visit conference.thoracic.org today.
And I guess, so in thinking about this, integrating this into our practice, is there like a particular clinical phenotype that you're thinking, like, oh, this is, I want to transition this patient, or I want to do a new start? Is there some patients we want to be more frequent dosing? Like, what are we there yet? I guess these are some thoughts.
Sure. I think about certainly the responders to the IL-5 inhibitors tend to have peripheral eosinophilia. In the study, they needed to have 300 per microliter at least 12 months before within 12 months of starting the study, and then 150 at screening, which is actually 150 is kind of on the lower side. So that's good to know that but there has to be some evidence of elevated blood eosinophils. So that wouldn't change. So I would want to look for that phenotype. In general, with the IL-5 inhibitors, the higher the eosinophil count, the better, the better response. But the study did show it with those criteria. So we'd look for that. And certainly anyone that's had an exacerbation, who's maybe tried other biologics in different classes, who haven't responded as well, or somebody who comes for the first time and has more of that kind of that eosinophilic phenotype, would be thinking about that opportunity. And so I guess the question is, would they be ready to go every 6 months or not? It would really be a shared decision-making situation with that patient. What are their goals of therapy? What works for them? Some patients don't want to give themselves an injection every month. They're kind of afraid of needles. So I've had a few who have to come in and get their injections in an infusion center or in our office because they don't want to give themselves an injection. So there's that as well. So that this sort of solves that problem or at least reduces the intensity of it. So again, I think we have a lot of choices now, but to be able to sit down and go over the pros and cons of each is what I normally do, and there's just a lot of choices now, so it's pretty exciting.
Yeah, I agree. It's just such an exciting time, and I'm looking for because I see COPD more, and mepolizumab was approved for COPD, so
Yes.
I'm always thinking like, what's up next for COPD as well. I also think this study was kind of interesting. Like it skipped phase 2. And I thought that was really neat. So like we're moving from phase 1 to phase 3, and they found clinical efficacy. So is that something we're going to be seeing more of as well, or is this kind of unique to the IL-5 class?
Right. I think because there'd been such experience with the IL-5 ligand, inhibitor with mepo, that I think that's really why I think and it was same company. There's, I think there's similar structure, that there was an opportunity to advance quickly. It'll depend on, there's so many other therapies coming online. Some are similar to others that are already here, but then others are very different. So I think it'll be really a context dependent or product dependent decision. But I like the fact this came online and really received approval very quickly.
Mm-hmm.
So it's nice for patients, to get the medication out in hands of patients sooner than later.
Yeah, and I think this is this something where I was reading about the biology of the how they made depemokimab. They like mutated it so it like evades like lysosomal degradation, so it just kind of recycles in your system. So is this something we're going to be seeing more of? I know that the RSV, right, the therapy for that involves this kind of the 6-month strategy, but I just can't. It seems like so much better for patients if we can use this technology, these new therapies with these ultra long dosing.
Exactly. Well, and that's happening in the HIV space too. They're going to every 6 months as well. So that's really nice. I know that there's some anti-TSLP products that are long acting as well. So they're the same kind of space. And so I think we're going to be moving that direction more and more in the field. I think because it's sort of the next step, and also you can, sometimes repurpose some of what we've already got into something long acting that could, benefit patients. Patients like that, tend to like it better. So I definitely see more of that coming online. And some are already under study, as I mentioned.
Mm-hmm. Yeah, I can't imagine, DD, have you heard much from patients about the 6-month strategy? Because I think, this was approved very quickly, but I believe the trial was in 2024. I think we were talking about it at our last podcast.
Right.
So I have not spoken to a patient who has actually taken this medication, but we have had a biologic patient advisory group that met in the fall of 2025. And we did ask some of these questions about the medications coming on soon in the pipeline. And so we do know that patients are very excited about the medications that are coming to help them with their severe asthma. The things that I would say that would be really important, and I think that Monica's covered some of this, but definitely setting expectations early, making sure patients know the process, especially with that biologics coordinator. That person is so very important to making this process take place. We've run a short survey looking at time of prescription to end of getting the medication, and sometimes it's a month or 6 weeks before, from the time I've written the prescription to the time I actually received to start the process, sometimes 4 to 6 weeks of getting that medicine. So that sometimes can be concerning. And again, just getting back to the mental health of making sure patients know what to expect so that they can follow through and that they can be successful on these medications, and that they recognize what their risks or what the adverse events might look like if they're having concern, and that they know who to contact. And then understanding what a specialty pharmacy is. Patients think that they sometimes can just, walk down to their general CVS, if you will, or other branded pharmacy, and they really need more support this way. So if they're doing home injections, recognizing this medication specifically is going back to your physician, but in biologic general education, making sure they know exactly what they need to be doing, or their caregiver, spouse, significant other, that everyone's on the same page with you as the practitioner.
So that's great, Dee. I'm glad you're having those conversations with patients, because it can be a complicated process from the time the prescription's written. And then like we have a specialty pharmacy, but then sometimes our specialty pharmacy isn't who the patient's insurance will cover. So then it has to go through another intermediary, and then there's phone, then they often mail the biologic to the patient, then they need a teaching visit. And so it's like a multi-step approach to really getting this going. But I think one piece that also I want to mention is just because it's 6 months in duration doesn't mean we won't see the patient for 6 months. I think that was to your question, to your point, Amy, that we want to make sure that they're feeling that things are going well with their asthma. How are they responding to the new biologic? And bring them in, to really do an assessment like you would with anyone, even on a shorter acting biologic, for the same reasons. So I didn't want patients to think that we were going to give them this injection and then not see them for half a year. It's not like that.
I'm glad because we're all social creatures, right? And our patients they do want to have that relationship with you as the physician. And so making sure that they are being seen, and again, just setting those expectations that maybe as time goes on, you might have the opportunity to kind of wax and wait a little bit longer, and because you're doing so well. So giving them the opportunity to hear from you that's they're on the right path.
Exactly. It's funny. I say the majority of patients are exactly like that. I have a few that are feeling so well that I have to chase them down to come and see me. So you have to come back. That doesn't happen. But it's a nice problem to have. But I like to have to chase them down.
It reminds me of the new drug that's out for cystic fibrosis. We hear from those families that they're either the adult or the child that's taking that new medication that they fully all have a new life and prefer not to go to the physician.
They don't really want to commit.
I actually I remember Dr. Kraft, you mentioned a patient who was feeling so well, they stopped their inhalers. We want to talk to them about that. That can get into trouble with insurance and things. But I had a patient like that. They were feeling so well that they just forgot. They just, so I think that's highlighting how important it is to bring them in, especially before the 6 months. And I think you were also mentioning that we don't know, like there could be, the dose could start to taper off, and we need to see them before that and set expectations, like you said.
Right.
Yeah.
And I was always trying to tell patients, if you feel like you want to stop your inhalers, let's talk about it. It doesn't mean that you can't, but just let me know instead of coming in off everything. So I feel like it's a partnership that we create together. And so that's all I ask is just message me and tell me what you're doing.
Right. Yes. Right. So I think really exciting time for asthma. Again, even more exciting. I think we're talking about what the future holds, and it sounds like maybe more of these ultra long dosing strategies. Anything else that we're kind of new and exciting coming out soon?
Well, I would say there is a whole host of new therapies in the works. There's a combination TSLP IL-13 inhibitor that's now in phase 2 and 3 trials. Certainly IL-33 is something that's being looked at a lot in COPD. There seems to be a little resurgence of interest in asthma because the data actually look pretty good in asthma. It looks similar to depemokimab, and that's why it didn't move forward, because depemokimab looked so good. But I think there may be a place for it because it's a different mechanism. It's an epithelial product, just what IL-33 is. There's a lot going on in the TSLP space between inhaled versus injectable, long-acting, short-acting. So several different trials going on in that space. There is an OX40 ligand that might have effects on neutrophilic and eosinophilic asthma. Gosh, there's many. I probably have missed a few, but that's just to give you a little smattering of what's out there. JAK inhibitors are also in play. Those companies who make JAK inhibitors want to come into the asthma space. And so it'll be interesting to see where this all goes, because we have a really great safety profile with our biologics for the most part. And some of these have side effects. So if they're going to enter our space, they're going to have to show a lot of good efficacy and safety to be able to compete with what we have. So it'll be interesting to see how it all plays out over time. It's exciting, definitely.
No, I think that's how do we, a lot of these studies are not head to head, right? So that's where we really need the expertise. We need those shared decision making with our patients. that's how, that's why you see your asthma doctor. because of
Exactly.
all the nuances. Yeah.
And then one other piece I'll mention, just because I think we may have touched on this before, is that patients are getting to the point where they're really well controlled on their biologics. So do they have to stay on it? Can they widen the dosing interval? Do they ever come off? I get that question all the time. And we actually have a few 2 grant applications that are being reviewed in the spring to really try to do these studies in a rigorous way, to try to really understand who are those patients who might be able to taper their biologics, widen the dosing interval safely, and still maintain control. Because right now it's kind of a it's a one-off type of thing where you might try it in your patient, but you don't have a lot of evidence to support who you might choose to do that. So more to come in that space.
Dr. Gardner, any thoughts from your perspective?
My thoughts are this, is that we've talked about shared decision making, we've talked about expectations, but we didn't talk about cost. And so, the cost of these medications can sometimes be inhibitory to some of our patients, depending on what their social determinants of health are. And so just being mindful of, inclusive and equity for all, that if there is an opportunity for patients to participate in clinical trials, to definitely try and diversify the participants in the future would be wonderful to see, so that these results can be generalizable. But also just making sure that patients and their caregivers are aware of patient advocacy organizations and also of patient assistance programs that can help with the cost of their biologic, so that they can be successful.
That's a really great point. I'm so glad you brought it up. I think I've been happy with some of the assistance programs that I've actually had patients of mine interact with. They've been very positive. And then, of course, the trial opportunities as well. But I'm actually impressed by how many of the companies have those assistance programs. So that brings me some hope that we can really provide this type of therapy to everybody.
Some of the patient advocacy organizations do have access to other assistance programs where either a church or a foundation may be willing to help with some of these medical costs too. So reminding healthcare practitioners that if they do have a patient that has a concern, to reach out to the different advocacy organizations.
Well, again, I think that was really exciting to talk about. Thank you so much, Dr. Kraft, Dr. Gardner, and look forward to seeing this implemented into our clinical practice. So thank you both.
Absolutely. Thank you for having us. Great to see you.
Thank you for joining us today. To learn more, visit our website at thoracic.org. Find more ATS Breathe Easy podcasts on Transistor, YouTube, Apple Podcasts, and Spotify. Don't forget to like, comment, and subscribe so you never miss a show.